Uh, Good afternoon. I think there's a number of people who have joined online. I'm Kevin Schwartzman with the REST program and also Associate Chair for Research in the Department of Medicine. And I'm really happy to introduce our colleague, Guillaume Fontaine, who's a nurse and a PhD scientist who leads the RISE 3 Implementation Science Lab at McGill and is a tenure track assistant professor of implementation science at the Ingram School of Nursing at McGill, as well as a PI at the Lady Davis Institute at the Jewish General. And Dr. Fontaine holds an FRQS Junior 1 award, supported by Quebec's Learning Health System Support Unit. He's also national co-lead of implementation science in the CIHR PHAC Canadian Network on Hep C and co-lead of methods in the Canadian HIV and STPBI's Clinical Trials Research Network. It's a mouthful, but and also holds visiting appointments in Sydney, Australia, and at the Ottawa Hospital Research Institute. So we're really happy to have you. And definitely when we're in contact about some of our QS stuff, and like when you said implementation science, kind of the light bulbs went on. This is something we're really interested in here, want to learn more about. Guillaume.
Thank you so much. Thank you for the invitation to present on implementation science and how we can leverage implementation science to advance healthcare for infectious diseases. Like Dr. Schwartzman's, as mentioned, I'm Guillaume Fontaine. I'm an implementation scientist. I completed my PhD in health services research at Université de Montréal and then completed postdoctoral fellowship in implementation science in Ottawa and also in Sydney. So here are my disclosures. So I lead the RISE Lab at McGill, Research and Implementation Science for Healthcare Engagement, Effectiveness, and Equity. Area one is mostly implementation science research to improve viral hepatitis, HIV testing, linkage to care and treatment uptake. I also study the interplay between implementation and related constructs in health equity. And I do quite a bit of research on the development of the different methods in implementation science, like pushing forward implementation strategies. And I use a wide range of methods across this research. And I also do implementation research in other clinical areas as well. I co-lead the implementation science stream of the Canadian Network on Hepatitis C. So Hep C is one of the key diseases that we're able potentially to eliminate by 2030. WHO, PHAC, the Government of Canada have set ambitious targets for elimination of hepatitis C, and we work across wide range of settings with a wide range of populations as well that have been prioritized within the blueprint for elimination of Hep C in Canada. And really, the implementation challenge from really an implementation science standpoint within this network is leveraging those methods from implementation science to ensure that we promote uptake of screening, diagnosis, and highly effective treatments, direct acting antivirals among key priority populations. So I've been working and co-leading this stream for a year now. Like was mentioned previously, I'm also co-leading the methods think tank within the new CIHR Pan-Canadian HIV and STBBI's Clinical Trials Research Network. And the challenge within this network in relation to implementation science is to expand the scope of trials that we're conducting within the network. So there's a lot of novel trial methods, adaptive and Bayesian trial methods that, yes, we need to put forward within the network, but also embedding implementation science within those trials, like conducting hybrid effectiveness implementation trials and implementation trials to generate more evidence on implementation outcomes earlier in the translational pathway. So this work is just starting now, but it's quite exciting. So I'm going to be talking about implementation science more generally, and also different ways that we can apply implementation science, and so show along the way some examples of how I've been doing that within the context of my work, and also some of the activities of the two networks that I've just presented. So why do we need implementation science? I'm sure that you've heard this many, many times before, but 30 to 40% of patients do not receive care that is based on current scientific evidence, and approximately 20 to 25% of provided care is unnecessary or potentially harmful. Within the last few years, we've seen also movements toward de-implementation with campaigns like Choosing Wisely Canada that have identified practices for de-implementation within multiple clinical areas. And this is part of the umbrella of also of implementation science. And there's also a lot of waste in spending in different healthcare systems globally. So the way that healthcare organizations typically approach implementation is often what we call the Isla Jot paradigm. So it seemed like a good idea at the time. So we tried something, didn't work out, but it wasn't really fully thought out. It's really an expensive version of trial and error because it's not based on things that we know work from an implementation standpoint. It's often insufficient. So we often omit factors that we should consider in implementation efforts that are quite important but are not considered. And it's also unscientific. So obvious approaches is developing and issuing guidelines, right? But these guidelines, the 10 commandments, will not self-implement. So we have to think about that. We're also often combining multiple implementation strategies, but more is not equal, does not equal better. We often have a favorite solution that we've tried for a previous implementation challenge, but doesn't mean that it's the right solution for the problem. And we're also often delivering training, education, but then is the content of the training addressing the key barriers to implementation? So what now? Well, evidence-based practice, it should be complemented by evidence-based implementation. And really, this goes back to the 90s, where Richard Grohl um, came out with a paper, advocating for an evidence-based approach to implementation, complementing evidence-based practice. This Legiata approach would be to plan a meeting, brainstorm solutions, somebody decides on a solution that we're going to implement, and then we go, right? The implementation science approach is really trying to fully understand the problem to maximize the chances that our implementation effort will be successful. So we're going to be thinking more carefully about those barriers and enablers and also those strategies. What is implementation science? So it is a field of applied health policy and systems and services research. It's really a multidisciplinary specialty. So it draws from decades of evidence in psychology, sociology, organizational theory, behavioral economics. The list goes on. And really, it seeks to develop knowledge about the methods and strategies that we use to promote evidence-based practice. Doing that, it draws from a range of methods and tools that build on those disciplines. And you can see the growth of publications that mention implementation science. And the onset of that growth was pretty much the publication of the launch of the major journal in the field, implementation science. There's also growing importance of implementation science for funding agencies in Canada and globally. So we have a number of these calls, implementation science team grants across different clinical areas, and also embedding implementation science into different research teams, different research networks, and also some project-specific calls that seek to leverage implementation science methods. So why is implementation science needed? So the traditional reason to use implementation science would be to think about the slow uptake of effective clinical interventions, which we often think about. But like we discussed previously, there's also the premature or continued uptake of clinical interventions that are shown to be ineffective, harmful, wasteful. And this is under the umbrella of de-implementation and linked, for instance, to choosing wisely. But there's also a failure sometimes to keep up with gradually emerging evidence about existing interventions that are currently in place, but that we need to change the way that they're delivered. Of course, there's a lot of health inequities and unwarranted variation in care that we need to address. And sometimes we also have a failure to keep up with the clinical ethics, and we don't have necessarily, 50 randomized controlled trials showing the effectiveness of the intervention, but like for ethical reasons, we should think about the implementation of an intervention, like advanced care planning, for instance. So when we think about implementation science, I think a very useful slide that is often used in talks around implementation science is to think about the thing. And this came from a paper that was published by Jeffrey Curran a few years ago. Um, so the intervention, the practice, the evidence-based innovation is the thing that we're trying to implement. Effectiveness research looks at whether the thing works. Implementation research looks at how best to help people and places do the thing. Implementation strategies are the stuff that we do as researchers or implementation practitioners to try to help people and places do the thing. And the main implementation outcomes are how much and how well the settings and places and providers do the thing in question. Another way to visualize this is that usually in a conventional clinical trial, we would look at the effect of an evidence-based innovation intervention or program, or just an intervention in itself on clinical outcomes. When we think about implementation research, we're going to be, like I just said, thinking about the implementation strategies, the strategies, actions that we're going to take to change to the barriers, to address the barriers and leverage the facilitators to implementation at different levels, at the level of the patient, the provider, the setting, the healthcare system. And this is ultimately going to have, we hope, an effect on implementation outcomes, service outcomes, and then ultimately client outcomes. So when we think about implementation research, we're really interested at developing knowledge on implementation strategies, developing knowledge on implementation barriers and facilitators, and also looking at implementation outcomes and service outcomes. And we have different methods and tools to address this. When do we do implementation research? So usually, I think I like this implementation science subway line of translational research. So looking at a given intervention, practice, treatment, tool. So has the practice of interest demonstrated efficacy? Yes or no? Has it demonstrated effectiveness? Yes or no? And usually we would do implementation research, around those green components here. So if we have partial or no effectiveness, no evidence of effectiveness of the practice or intervention, we could consider doing a hybrid effectiveness implementation trial. And if we do have evidence of effectiveness, then we could essentially consider doing mixed method studies to understand the context of implementation, designing implementation strategies, and evaluating those strategies. Really the centerpiece of implementation science are the theories, models, and frameworks and the different methods that we use. If you're doing implementation science but not using those tools, you're kind of doing it wrong. So really we have three main areas of theories, models, and frameworks. The first one is process models. So those models seek to guide the process of implementation in different stages. And then we have frameworks that help us understand the barriers and enablers to implementation, the middle piece. And we have frameworks that help us evaluate implementation as well. A key process model, for example, is the knowledge to action model that a lot of most people know. Structures the process of translating research to practice in different stages. So identifying the knowledge gap, adapting the intervention to the local context, assessing barriers, and selecting implementation strategies. Then if we think about how to assess barriers and enablers to implementation. So what would be a typical approach and what does that involve? The most used framework globally to assess barriers and enablers to implementation is called the Consolidated Framework for Implementation Research. It was published in 2009 and recently updated. And really, this framework gained recognition in the field because it consolidates a wide range of frameworks from different disciplines, organizational theory, sociology, psychology, into what we know are the factors that influence human behavior change and implementation in the context of an organization. It includes a wide range of constructs, but structured across 5 domains. So the innovation in itself that we're going to implement, the outer setting, which would be the healthcare system, the broader organizational context, the national policy context, the inner setting, which is the organization or the unit or the clinical setting that we're looking to implement the innovation in, individuals that are involved in the implementation process, and the implementation process in itself. So really, if we're looking to assess barriers and enablers to implement the implementation of an intervention, we would look at assessing those different factors at different levels. So looking at, for example, the innovation domain of the CFIR, you would ask questions, whether in the context of a survey or an interview, what is the perception of the stakeholders around the evidence that is available to support the effectiveness of the intervention. What are the specific advantages of this intervention over another? Is there a way that this intervention can be tailored to suit a given context, and so on? And you have similar questions from for the different other domains of the CFIR as well. Usually when we would assess barriers and enablers to the implementation of an intervention, and we want to generate knowledge around implementation barriers and facilitators, we could do qualitative studies. So this is what is often done. So a single site or a multi-site interview process with relevant stakeholders at different levels, or focus groups, field observations, document reviews, structured according to a determinant framework like the CFIR. What's often done as well is cross-sectional studies with questionnaires structured around a determinant framework, knowledge synthesis as well to reinterpret evidence on factors affecting the implementation of an intervention with an implementation science lens. But there are also some additional methods like rapid appraisal methods where you can do informal consultations with key informants to think about those barriers and facilitators. And briefly, usually the approach that we take would be to rate the different factors that we identify using those methods according to different levels, identifying major barriers, minor barriers, and also major facilitators and minor facilitators, but also some of the factors that are in between sometimes that have a mixed influence on implementation. And this assessment can be done in different ways. It could be frequency at which the barrier comes up, but also the intensity about which the stakeholders are talking about a given barrier, for example, and also the expertise of the team. So this is just a really simple study that was done to illustrate the process at a foundational level. So, interviews with 15 or so key informants on barriers and facilitators to the implementation of point of care testing for viral hepatitis C. And you can see that across some of these constructs, there's more green, which means that for each given person that's interviewed in this context, in this small sample size, represents a major facilitator, minor facilitator to implementation when it's in green. And when you have red, it means that it represents barriers to implementation. So essentially for point of care testing, for example, for hepatitis C, you can see here that a lot of the stakeholders perceive that there's a lot of evidence supporting the effectiveness of point of care testing, and they perceive the advantages of point of care testing versus centralized lab-based testing, right? But you can also see that there are some barriers emerging around the complexity of point of care testing and also the IT infrastructure that needs to surround testing in itself. So this is really at a small scale, but it kind of illustrates what we're trying to get at with the process of assessing implementation factors. Two examples of that you can look up are a study that we did, a multi-level study that we conducted to assess barriers and enablers to hepatitis C screening in provincial prisons in Quebec. So we interviewed people from, the Ministry of Health and Correctional Services down to people who are incarcerated at all levels to map out the barriers to implementation. Now that we have identified barriers and facilitators at different levels, the next stage of a typical implementation study would be to look at selecting and tailoring the implementation strategies that they're going to overcome the barriers and amplify the facilitators to implementation. So what are implementation strategies? They're methods or techniques used to enhance the adoption, implementation, and sustainability of a clinical program, intervention, practice, policy, model of care, and so on. Two major lists of implementation strategies are being used today. The main one would be the one on the left-hand side, the ERIC implementation strategy taxonomy, and you also have the EPOC taxonomy. So those two provide essentially a repertoire, an ingredient list of multiple things that you could select to enact change and support implementation. And why is it important to think about the selection of implementation strategies in more detail? Well, one key reason is because usually there's little association between the type of problem and the approach to change taken. If you look at the implementation studies that were conducted, they're going to have strategies like education, targeting mainly beliefs, knowledge, skills, where the problem is an organizational culture problem, which doesn't link. So that's why we need to think more carefully about those strategies. The thing is that there's no universal strategy that works for all barriers and facilitators. So we need to think about really what ingredients we're going to select to, develop our recipe, our implementation recipe. And essentially in implementation science, this is what we need to do. We need to select the most appropriate ingredients to address the identified barriers and building on existing knowledge. So we're not going to be reinventing the wheel, but drawing from the body of evidence. So when we select implementation strategies, we have a process that we follow that's usually structured like this. First, considering what are the key implementation barriers, facilitators. Next, thinking about how will these strategies work, really? What are the mechanisms of action of the strategy? So if we're talking, like I said, about pro educating providers or patient around a clinical intervention or issue, well, we know that this is going to increase knowledge, not going to alter organizational culture. So this is what we mean by thinking about the mechanisms of action. And then what is the empirical data around the effectiveness of those implementation strategies? And I'm going to present some of that to you. And then what are the available resources within the context and the practicality and logistics of delivering the strategies? So it would be in that order. So the ERIC implementation strategy taxonomy is the main list of strategies that's being used today. So it documents 73 different implementation strategies in 9 groups. So these are all of the strategies. Some of the clusters we know quite well, like for instance, training and educating stakeholders, using financial strategies, changing the physical IT infrastructure. But some of the other strategies on the left-hand side, we know a bit less. And they're really the core of implementation science around developing stakeholder interrelationships, providing assistance, adapting and tailoring to context, and using evaluative and iterative strategies as well. Take a quick sip of water. What's interesting as well is that those researchers that developed the taxonomy of implementation strategies, they said, okay, we're going to do a study where we're going to ask, 150 implementation scientists, what are the strategies that are the most feasible and important, regardless of the context. And essentially, all of the strategies that are in the green quadrant, according to a study that they did, were deemed the most feasible and important to consider first when doing an implementation study, like having a formal implementation blueprint, conducting a local assessment of the needs for implementation within a given setting. So I think that's quite interesting. Our team, we just conducted the largest systematic review on the effects of implementation strategies on clinical practice and patient outcomes in nurses, published last month in Implementation Science. So we looked specifically at 19 implementation strategies, clinical practice guidelines, a bunch of strategies around education, reminders, patient-mediated interventions, audit and feedback, and so on, down to champions and tailored interventions and local consensus processes. So with no surprise, the top strategies that are being used to support clinical practice, and these results, by the way, are pretty similar across disciplines and healthcare providers, if you compare that with the evidence in other disciplines. But essentially, educational materials, educational meetings, clinical practice guidelines, reminders, audit and feedback, educational outreach, tailored strategies, champions, patient-mediated interventions. And the rest of the strategies, and this is only a subset of 19 strategies out of 73, there's really underuse of many, many strategies. And this is an overview. So we did a meta-analysis of the effects of strategies on continuous dichotomous clinical practice outcomes, and the same for patient outcomes. And essentially what you can see here is that, those strategies, any implementation strategy versus none, there's a pretty large effect on supporting clinical practice. We compared the effects of multifaceted strategies, so combining education, audit and feedback, and so on, with just a single strategy to see what would be the differences. Minor benefits really of combining multiple strategies with a single strategy. And I would also like you to look at this one. So reminders, there's a lot of evidence around the effect of reminders on clinical practice. And the other big body of evidence would be around the effects of tailored interventions on clinical practice. So essentially, tailored interventions are strategies that were selected based on local barriers and facilitators to implementation. Um, so we have good evidence to around the fact that the strategies that are being developed and put forward and the content of those strategies that is being adapted to address local barriers and facilitators are more effective than other strategies to support clinical practice, but also to enhance patient outcomes. And then once you have selected your different strategies, you would think about specifying the different dimensions of those strategies. So who's going to deliver the strategy, who would be the target of each strategy, over what time frame, over what frequency as well, what types of outcomes would be affected by each implementation strategy. So that would be the last phase of development. And briefly, I'm going to talk very quickly around evaluation. So the evaluation of implementation. So often when I talk about implementation science, there is often a reflex to go to evaluation really quickly. So we want to look at evaluation, but really the whole of implementation science is also looking at those previous steps. But of course, evaluation is part of it. And we have some frameworks to support that as well. One framework is Proctor's taxonomy of implementation outcomes. So when we would be thinking about evaluating the impact of an implementation strategy bundle, we would think about evaluating that on those implementation outcomes. The acceptability of the evidence-based intervention, the adoption of the intervention, the appropriateness, feasibility, fidelity, cost, penetration, and sustainability. You also have a wide range of study designs to conduct evaluation and implementation science. One paper that I really like is this one in the BMJ on designing and undertaking randomized implementation trials, but those two other papers are really quite well done as well. In this first paper, there's this table that I find quite useful to compare, a typical clinical public health trial to on the right hand side an implementation trial, and in between the different types of hybrid effectiveness implementation trials that you could consider conducting. So essentially, those trials in the middle assess both effectiveness outcomes, clinical outcomes, and also implementation outcomes. And in the case of the middle one, for instance, there's a co-primary aim to assess the therapeutic effectiveness of the intervention, the clinical intervention, and the effects of an implementation strategy on the implementation outcomes that I've presented. So now to close it off, I'm going to be talking about a few examples of studies that I've been conducting and collaborating to across Canada and Australia, leveraging implementation science. The first example being a recent grant, a CHR grant, that's looking to establish the framework for scaling up decentralized point of care hepatitis C testing in Canada. And in this context, we're doing some process mapping that I'm going to be just presenting on the next slide. But then we're going to be looking at the barriers and facilitators to implementation of point of care testing using some of those methods, co-designing implementation strategies in the same way that I've just presented, and then assessing some preliminary acceptability, feasibility, and costs of those strategies in preparation for scale up. The main methodology that we're using across this study is a clinical implementation science process mapping. So essentially mapping different clinical pathways. In this case, we're mapping the hepatitis C care cascade. So from patient identification to antibody testing, RNA testing, linkage to care, treatment initiation, SVR, sustained viral response, and then prevention of reinfection. So really mapping across the different sites that we're working with. So we're working with community organizations that are dedicated to the prevention of transmission of STBBIs, but also prisons. So mapping the clinical pathway in this context for HCV diagnostic and treatment. Then at the same time, we're using those implementation science frameworks and tools to assess barriers and facilitators at different stages. And we are augmented those maps with clinical audit data to see, across different stages, how many people were tested, linked to care, initiated treatment, and so on to map out as well the clinical pathway from the patient perspective and using an objective method. So for example, we start out with a very simple process map that looks like this. And this is the process map that we're using in Australia, but we're going to be using a similar one in Canada. And we go in discussions with clinicians, managers, peers that are involved in the delivery of care within those settings to expand the process map for a given setting and look at those various facilitators and clinical processes with them. And this is going to be the basis of understanding the barriers and designing implementation strategies. Another way that we're using implementation science in the context, in a way that I think is pretty novel, and is in the context of a series of systematic reviews that we're conducting on point of care testing for HIV, viral hepatitis, and STIs. So we're doing some typical reviews on the effectiveness and cost effectiveness of point of care testing, but then using those implementation science frameworks to do a mixed methods review on barriers and facilitators, and using the ERIC taxonomy that I've presented to look at the effectiveness of those implementation strategies. And finally, I'm doing some work within the National Australian Hepatitis C point of care testing program, which is one of the first globally to scale up point of care testing for hepatitis C on this scale. So it's established across all of the Australian state and territories. It includes essentially point of care testing in the community, in drug treatment clinics, mobile outreach settings, homelessness organizations, and so on. It includes antibody testing and RNA testing, as well as HIV point of care testing and hepatitis B point of care testing. And the program includes logistics, deployment, blood collection devices, training, connectivity, and so on. And up to now, around 30,000 people have been tested within the context of the program. So we're using essentially implementation science to develop the living program impact theory of the program to see how it is achieving its intended impacts. So we're looking at what are the barriers and enablers to the implementation of the program, what are the implementation strategies that are used within the program to ensure the effectiveness of implementation and the reach and those implementation outcomes. And then we're also using some frameworks to explain the underlying mechanisms of change, assumption, and so on. And this is an overview that I like to show around some of the preliminary results for where the key factors affecting the implementation of the program are located. So there's a lot of factors related to the site and setting level, a lot of factors related to the national health and state system context, factors related to point of care testing in itself with its complexity and effects, the individuals that are involved within the context of the national program, and factors related to the implementation process and the research process that are affecting positively, but mostly negatively implementation. So the key barriers lie in those areas. And then we're also, this is a bit geeky, but mapping out the implementation strategies that are used across the national program. So you can see that there's a lot of different strategies that are related to adapting and tailoring point of care testing to suit the local context, each site. A lot of strategies that are related to developing and upholding interrelationships between the stakeholders at different sites. Training and education, of course, changing the physical and IT infrastructure, and then engaging consumers. So I think it's quite interesting to yes, see which strategies are being utilized, but also look at which strategies are being underutilized. And this is where potential additional strategies could be developed and put in place to additional scale up of the program. So in conclusion, how does this all come together? So remember the thing, implementation science, the principle is that you have an intervention, the research evidence shows that it works. Then you need to think about how do we support health service professionals or patients to use the intervention, thinking about the likely barriers and facilitators to implementation. And the key principles are that there's no magic bullets to address those barriers and facilitators. So you need to think about the strategies in detail, and then thinking about how will you know that the strategies are successful. Thank you so much.
Thanks so much. It was really, really informative for me as a researcher who doesn't do implementation research. Uh, my question relates to, in your experience, when is the best time for someone who does clinical research to entertain an implementation aspect to, say, a research project or a grant? Because it seems like you want to establish that an intervention is effective. Um, and then implementation is sort of equally important almost, because if you don't implement it well, then it doesn't matter. But you mentioned at points in the presentation where you could consider having a trial where you're evaluating both simultaneously, but that sounds like it might be hard to get funded, because I could see a reviewer say, well, if it's not effective, then we don't care about implementation. So do you think, is it wiser to um, pursue the implementation piece, which is critically important after? Like it sounds like in Australia, they've rolled it out in some ways, and now you're kind of in real time trying to figure out what's the best way to implement. I don't know
Mhm.
if that question came across clearly, but what's the strategic way?
Yeah, that's a good question. So there's a big debate within implementation science around the level of supporting evidence that you need to have to then go into implementation. So is it like how many trials do you need and so on? And some interventions need to be like we were talking a bit about earlier. If it's very straightforward and you have a treatment, a medication, a diagnostic test, or something that's really quite easy to define, then it's kind of easy to map what the evidence you have. But if you're talking about the implementation, sometimes of a more complex behavioral intervention, social intervention, or complex intervention, then the supporting evidence is kind of a bit more, you don't, it's a bit more up to debate, let's say. But I would say that you need to think about a lot of the people that want to do those hybrid trials. So the ones that you saw that are kind of in between hybrid type 1, type 2, type 3, a lot of people are doing hybrid type 2 and 3. So they have pretty good evidence on the effectiveness of the intervention before coming in and going and doing some implementation research. But the idea is that you're doing some of those implementation outcomes are not it's not a lot of data on the top of the effectiveness outcomes to collect. Essentially, right, you're looking at some potentially additional questionnaires, but some of those measures are process of care, quality of care kind of measures, which you can already sometimes collect in the context of a trial, but they're just not framed patient outcomes really. So we also need to think about that, right? To kind of capitalize on what we're already doing. But I would say that, the earlier the better, but once you have at least established the efficacy of the intervention for sure, right? But the effectiveness then um I think pretty early in the effectiveness kind of translational pipeline, we should consider those trials. Yeah.
Thanks.
Uh, Thank you, Guillaume, for a brilliant talk. Yeah, it's a real eye opener. I guess one comment, or I guess presumably what you're implying is that in the case of sort of the hybrid trials, would be more a pragmatic type trial that you might piggyback or combine with implementation questions. Is that correct?
Exactly. Yeah.
Yeah,
Yeah.
great. I guess so. I guess the question I have, like another comment, is I see that there's obviously a huge sort of theoretical or very rigorous theoretical underpinning for this, which is good to see, and I think which many of us are less familiar with, quite frankly. But at the same time, some of it was a little bit overwhelming, like 70 plus items, like, oh my goodness. But I know obviously there's a way to be efficient in that regard. But I guess my question was, I have seen and have been involved with different sort of theoretical model, shall we say, in the implementation science world. So actually, the one that I'm most familiar with is the REAIM framework, which you
Right.
didn't touch on. And I'm just kind of curious how specialists like you kind of navigate that and decide, for example, what theoretical framework you consider most important for a particular question or project.
Yeah. So that's a good question that comes up often. So we conducted a number of reviews of implementation science theories, models, and frameworks, and we've identified, I think, 600 or something going back to the 80s. But it draws from different disciplines. So But of course, just a small subset of those at the top are being used widely, right? So you have a lot that's just not so good. Um, Usually, when we do an implementation study, we would need three frameworks, right? So at a minimum, you should have a process model. So guiding what are the different steps? Step one, engaging stakeholders and people. Step two, assessing barriers, selecting strategies, evaluation. Just a framework that's quite simple, outlining different steps. So for a process model, then you would need a determinant framework to guide how you're going to assess barriers and enablers if it's something that's relevant within the context of the study. Sometimes you're not necessarily looking for assessing implementation barriers and facilitators, depending on the context of the study. And then you need an evaluation framework at the end. And REAIM is one of those. So REAIM is, used really, really widely and super well known, of course, in public health. And it's one of the top two evaluation frameworks with Proctor's taxonomy that I've just presented. One of the limitations of REAIM is that, there's reach, effectiveness, adoption, implementation, maintenance. But I would say that the way that they're defined sometimes, the framework has been operationalized in different ways, but maybe there could be a bit more specificity about those implementation outcomes across the different stages of REAIM. But it's a good framework to have for sure if you're looking to evaluate an implementation strategy or within the context of a trial.
Thank you.
Yeah. Right. Question. Thank you very much. Oh, that's like the best presentation I've seen on implementation science, where I learned actually. Thank you for laying it out so nicely. I was curious about, so you presented one case study on hepatitis C. What is what is that? ISGAT?
It's
Uh,
plagiat.
yes, for that particular case study, you showed us how with the flow diagram, how you're
Right.
going to, what's going on in practice.
Yeah. So I mean, within the context, it depends, right, on the setting. So it could be that, for example, I'm working within a community organization, right, that's looking to do some testing for Hep C. So they have some testing practices in place. So what they're doing is typically, okay, someone is going to come in on Wednesdays, like a nurse is going to come in and do some testing for 2 hours and then come back next week. And then we don't really know how the transition of information or like the referral of patients is going to function within that specific setting. But they've designated someone to do testing, but I guess the processes within the setting are not clear. So that would be a bit of a isla jot. We've identified someone to do testing and opportunity to get tested every week and so on. But then there's big gaps in terms of how the role of the person was deployed and also what are the processes and what essentially is the model of care within that setting to make that work. So the isla jot would be to do it that way, not in a structured process. Then the implementation science way would be essentially what we did was like go into those settings, interview the different workers, the managers, the program coordinators, the physicians around, kind of see what are the barriers and facilitators to having testing, point of care testing within the setting. And then depending on the key barriers, for instance, we don't have lack of confidential space to perform testing, announce the results, or lack of, materials, equipment, or like the professional roles within the setting need to be adapted because the workers in the setting are not used to doing pre-test counseling for HCV and don't know how to effectively refer patients to the person who's going to do the testing. So really the implementation science would be looking at those barriers, different places, and then doing some targeted strategies like looking, okay, we're going to do additional we're going to restructure the workflows to kind of do some task shifting, whereas some workers are going to have more of a role for hepatitis C, doing some additional, developing some additional tools to support clinical practice in terms of like a guideline or an algorithm for instance, for testing, doing some training around pre-test counseling for workers, and then so on, right? So we would do kind of a bundle of strategies, and then that would be the implementation science informed approach versus what they were doing before, which was just, okay, we have someone for testing, we've disseminated on a poster that we offer testing, right? So that would be kind of the two, I guess, ways of going about it.
Not carried out in that particular sequence or the duration between them. Suboptimal.
Right, right, right. Well, I mean, point of care RNA testing right now in Canada for hepatitis C, it's not deployed widely, right? Some sites are doing RNA testing for hepatitis C to have a diagnosis in 60 minutes or less. Some sites do, I don't know if you're familiar with the care cascade for hepatitis C, but you need to do an antibody test to confirm exposure and then do an RNA test to confirm active infection. Because A, the infection can be cured by the person without treatment in some cases, like 20%, or they could have had a past treatment. So you need to do a second test. So the idea for that point of care testing study is to do point of care antibody testing with like a quick test, insti test, life lasting a few minutes, and then RNA testing with a gene expert machine. So some of those machines were used for COVID in indigenous settings up north. To repurpose some of those machines to put them in high prevalence settings for hepatitis C, like needle and syringe programs, prisons, mental health and drug treatment clinics, things like that, to leverage those high prevalence settings to do point of care testing and have results under an hour. And now in Australia, what they're able to do, and they're really the leading country globally for that, is to do point of care antibody testing, do point of care RNA testing, have a diagnosis in 60 minutes, and then give a package with medications for Hep C and you go home, right? So that's really quite innovative. And that's what we need to achieve elimination. But in Canada, we're really we're not yet there yet. So yeah, we need to do some work. And that's why we're doing all of that clinical process mapping to look at the current processes, opportunities for intervention, barriers, and so on.
Thank you. I think there's other questions. I do have another.
Oh, go ahead. There's one question in the chat from Alton Russell. How much capacity is there in Canada for IS relative to the need? If we all want to add IS to our CIHR grants, how would we go about identifying an expert and recruiting them to join our proposal?
Yeah. So that's a good question. So there's a lack of capacity. There's some networks there's different centers in Canada. So there's a Center for Implementation Research in Ottawa. If you Google implementation science centers, knowledge translation programs, and so on, you're going to end up on multiple different programs across the country. Not much in Quebec, I would have to say. We have expertise, but it's very localized in some areas. And I think a big I'm going to go back to the grant aspect, but a big program that I am advocating for is the lack of academic programs developing skills in implementation science at a level that's pretty advanced. And two aspects of that, we need to develop additional implementation scientists, but also implementation practitioners that are going to be working in hospitals and the MUHC to just apply those methods and not do research on them, right? And not advance the knowledge. So I think there's a critical skill gap and so on. In the US, there's a big push right now to open up dozens of implementation science centers across different universities, and then develop academic programs, so masters and PhDs in implementation science. So they're really, Canada was leading in implementation science for maybe 15 years because I did my postdoc with Jeremy Grimshaw, the Center for Implementation Research in Ottawa, where you have Ian Graham. He was the vice president of CIHR for knowledge translation and so on. And you have a big group of people, but those people are starting to retire and so on. So um, anyway, there's a lack of capacity, but I think if you look up those resources online and you identify implementation scientists, I think you're going to be able to do it. And then you also have within some of those universities, you have resources in implementation science, right? So there's within those implementation science centers, often they have a list of really great resources to support grant development. There's also in the US a big HIV implementation science coordination initiative based at Northwestern University. So they have a portal online with amazing implementation science resources and tools and so on that you can look up. So I would say identify key people, leverage those resources, and then we have to go with that for now.
Thank you, Guillaume. This is a very interesting presentation. I was wondering if you could tell us a little bit more, sorry, about de-implementation science and what the steps of that process look like.
Yeah, so de-implementation. So I'm doing a little bit of de-implementation. So there's one of my PhD students. She's working to de-implement coercive practices in acute mental health care. So seclusion and restraint, use of chemical restraints as well in acute mental health care. So she's looking at de-implementing those practices. So the body of evidence right now says that the strategies to support implementation are quite different from the strategies for de-implementation. So for instance, for de-implementation, there's a bigger emphasis on behavioral substitution. So if you're not doing this, what are you going to do, right? Sometimes you can't do nothing, right? So if you're going to de-implement coercive practices in mental health care, I would guess that you're going to have some do something instead, right? To kind of make sure that the patient is handled kind of safely and, nothing bad happens. So we have a bigger emphasis on behavioral substitution strategies. And there's quite a few of my colleagues that are specializing in the implementation. So I think that's a very up and coming issue because, of course, it's a lot of cost cutting in the healthcare system could come from the implementation and just thinking about the clinical relevance of what we do and yeah. So the body of evidence is emerging, but it's saying that we have to do things differently.
Thanks for your great presentation. Just I have a question regarding is there any relation between the transfer technology in McGill University and submitting a patent and then converting to implementation and going to innovation? Is there any way to do that if we submitted before a patent in McGill University?
So you're asking if there's a way to transition from having a patent to implementing a patent on what? Just any kind of intervention or treatment or
in AI-based method. It's a AI-based framework in the health, and that would be transferred technology to McGill, but I'm wondering how it could be used as an implementation center. Is it possible to transfer to implementation process?
I'm not sure I understand fully the question correctly, but I mean, there's different things. So first, we have to be really specific about what we're implementing or not de-implement or de-implementing, right? So a lot of sometimes interventions, okay, we want to implement this intervention, but then the components of the intervention are somewhat unclear. A lot of the work that I did recently is mapping out the series of clinical behaviors that we need to change essentially when we're implementing something. So there's often complexity in defining what is the implementation object. But I'm not aware of necessarily transitioning from patents to implementation specifically. I think you mentioned AI, right?
Yes, AI
So one of the projects that I'm starting up right now is to look at partnering with some people that have been leveraging implementation, artificial intelligence in the context of implementation science to summarize using AI, what do we know about barriers and enablers to implementation for a given intervention? What do we know about effective strategies? So there's people in the UK and Australia that have been doing some of that work. So I think it's a really promising avenue for having more efficiency within the process, right? So we want to ask a question, we want to know what are the best strategies, we can ask that and have the evidence. So that's a bit around AI, but yeah.
But actually, because in my opinion, just submitting as a patent is not enough. It's good to go to application.
Right.
So implementation center can help to go to use this methodology and framework.
For sure, for sure. It needs to be an active process, right? So if we just, put out patent or a guideline and we do nothing after that, for sure it's gonna stay on the shelf. Yeah.
Thank you. So you had a graph there of what feasibility versus importance or vice versa. I was just wondering if you could explain what are the points on that graph? What's clearly the upper right quadrant is the good quadrant.
Right.
What's all the other? I was just wondering, what is this? What are these points?
Going back to it.
The bad quadrant, for example.
Yeah. So you mean that, right? So the strategies that are in the green quadrant, and all of the numbers represent the 73 implementation strategies within the taxonomy of ERIC. are the strategies that were deemed by experts in implementation science to be the most feasible and important to consider first when implementing anything. And those that are in the gray quadrant would represent those that are perceived to be less feasible, maybe less important, but you still have to consider. So, I mean, it's just, I guess those strategies can be considered as the low-hanging fruits of implementation science, that you kind of need to go for these one first, and then you consider the other ones. But you would have to look at the paper, Waltz and colleagues, 2015, ERIC implementation strategies, if you Google, to have the full context of that.
Thank you.
Yeah. Thank you so much.